So good morning, everyone. Based on the details you have given, we made a small presentation. I'll just present it. Dr. Sylvester, just let me know once the presentation is over. Just let me know if some more details have to be added to this, or if there are any corrections.
Okay, sir. Okay, sir.
A 51-year-old male resident of Big Lapati, Karnikobar, who was previously treated for extensively drug-resistant pulmonary tuberculosis. He presented to the district hospital, Karnikobar, in the month of April 2025 with a 1-week history of productive cough. So he is a known diabetic on irregular medication and has a history of chronic alcohol use.
Yes, sir.
He had 2 episodes of TB in the past. In 2022, he was diagnosed as drug-sensitive pulmonary TB, and he was treated with DSTB regimen for 6 months and was declared cured. And later, almost within 6 months, he again developed symptoms, and this time he was diagnosed with pre-XDR TB. In addition to MDR, he was resistant to FQ, and also the second line injectables were resistant. So he was started on modified longer MDR regimen. Levofloxacin was replaced with delamanin, and he took treatment for 18 months. And we don't have the last culture report yet. The second last culture was negative. So he was declared completed the treatment. So this time we have so far these many investigations done from your side. Chest X-ray done on 24th shows non-homogeneous opacities in the left upper and mid zone. And sputum CBNAT was done, which showed presence of MTB with rifampicin resistance. And sputum smear microscopy was done, which showed 2+. So hence, this is a case of microbiologically confirmed. So this was the X-ray which you have sent.
Yes.
So this is a case of bacteriologically confirmed rifampicin resistant pulmonary TB so far. So you've done so far the pre-treatment evaluation, though it's not complete. We have so far these many information. HIV is negative. FBS is fasting blood sugar is 125, and his CBC is within normal limits. His LFT is deranged. As we can see, AST and ALT is slightly more than the upper limit of normal, and bilirubin is double the upper limit of normal. And otherwise, other parameters are all normal. ECG has been done. QTC is normal, 405 milliseconds. So these tests are pending in pre-treatment evaluation. Serum electrolytes is not done because of technical issues there. And then visual acuity has not been done. Hepatitis markers are also not done. Okay, so Doctor, you want to add something to this? Any further information or any corrections in the case?
Hepatitis done, sir.
Hepatitis B marker done, sir.
Okay, it is.
Surface came negative, sir.
Okay, all right. Okay. Now electrolytes are pending, right?
Yes, sir. Reagent is not available, sir.
Okay, sure. So now I'll ask Dr. Natraj to further take on the.
So what we will do for this case now is we will start him with again all oral bedaquiline containing regimen for 18 months. But this time again we have to give him on delamanin because he is FU resistant. So anyways we will be you will be sending the second line LPA and also the drug sensitivity testing, isn't it? So for now we will start bedaquiline, delamanin, enizolid, clofazimine and cycloserine. But one thing you have to be very careful is we are not getting a psychiatry opinion for this patient because psychiatrist is not available in that part of the Nicobar. So what we can probably you can do is along with it, you can even give a differentiated TB care for this patient. So by differentiated TB care is you keep him in the hospital for a minimum of 2 weeks. So that he has this alcohol-free period also. And since we are starting him on ATT, we also has to monitor periodically his liver function test. And also obviously we have to do ECG after 14 days. So we will start him on ATT of bedaquiline, delamanic, clofazimine, cycloserine, and we will not give levoflox. For that only we are substituting with delamanic. We will initiate differential TB care for him. By differential TB care, we are keeping him in the hospital for a minimum of 14 days. And we have after 14 days, we have to repeat his ECG to monitor the QTC because we are giving him both delamanic and bedaquiline. And we have to also monitor his LFT. So after starting, because linezolid can also cause hepatotoxicity, and his bilirubin is 2.6. So we have to repeat an LFT after 5 days. Do you know the body weight of the patient, Dr. Sylvester?
Body weight is 73 kg, sir.
So what we will do is, so we'll start clofazimine 100 mg, linezolid we will start 600 mg. Yeah, we'll send that all that to you.
Okay.
In minutes, we'll send that all that to you.
Okay, sir. Okay, sir.
Dosing details and all, we'll send it after.
With the minutes, we will send them all.
We'll mail it.
We'll mail it
to the DTO.
Okay, sir. Okay, sir.
If you want to ask anything?
New case available.
Sir, one more new case is there, sir. Female patient,
Okay.
41 kg.
33 kg.
41 years old female patient with 33 kg, sir.
Okay.
And she's a case of rifampicin resistant MDR TB, sir.
Okay.
And no history of means TB in the past, sir. Directly.
So we have done all of the pre-treatment evaluation for the patient.
We have sent today only, sir. Tomorrow we'll get the.
Okay, then once it comes, we will discuss about it like this only.
Okay, sir. Okay. Okay, sir.
Okay. Okay.
So regarding this case, do you have any further queries or something? So that.
Sir, to repeat LFT after 5 days, no, sir, for this patient?
After initiating of ATT, we will repeat after 5 days because on rare occasions, linezolid is also hepatotoxic.
Okay, sir. Okay, sir. Okay, sir.
And please ensure the adherence since he's alcoholic. Please have frequent home visits and assign a treatment supporter for the patient. So once the patient is discharged from here, so his adherence has to be monitored. Yeah,
sir,
one
more thing. I think so. He's a diabetic also, sir.
Yeah.
So what are you giving for his diabetes right now?
He's actually he's getting chlorphormine G2, sir, BD.
Okay. So when he is admitted in the hospital, just monitor the sugar levels 3 times a day. Do a GRPS monitoring 3 times a day. So we will come to know with the G2 sugars are controlled or not. If it's not controlled, then we will see what to do next.
Okay, sir. Okay, sir.
You said chlorphormine G2 TID, right?
G2 chlorphormine G2 no BD, sir, twice a day.
Okay, all right. And he's not on any further medications, any other medications, right?
No other medications, sir.
Okay.
Okay, sir.
All right, so we'll send you the minutes and whatever recommendations Dr. Natraj has given, we'll send it to DTO's mail, so you can follow it up accordingly. So if you don't have any further queries, we'll wind up the session for now.
Sir, so from today onwards, we'll start the treatment, no, sir?
Yeah, we can say yes.
Okay, sir. Thank you, sir.
Thank you so much.
Thank you, sir. Thank you so much.
Thank you, Nicobar team. So like this, will be you can contact us anytime if you have any more such cases. our medical team from Nicobar, obviously there's shortage of lab facilities and also specialists. So Dr. Sylvester, please feel free to contact us for any other assistance.
Okay, sir.
Okay.
Thank you, sir.
Thank you. So with this, we'll wind up our first difficult to treat TB clinic. So we'll send whatever management protocols Dr. Natraj has already discussed with the team. We'll send a detailed report to the DTO email. Thank you, ECHO team, for facilitating in such short notice, creating this program and facilitating our first ever difficult to treat TB clinic. Thank you.
Thank you, sir. Thank you, sir.
Yes.